Okay, I think we will get started now. We're expecting several more people to arrive, but we'll just get going here. So today we're providing a webinar entitled Understanding and Helping Depression, presented by myself. Portions of this were presented at the last ISNR conference in October, and we'll review some of this information today as well. So here you see a pretty old comic strip with Charlie Brown going to Lucy saying he has feelings of depression and what can he do about it, and she just tells him to snap out of it. So these days in our society, we're looking for quick fixes for problems that may be of very, very long-standing origin. Here you see some images reflecting what depression is. This is actually very interesting for me. I was thinking this morning thinking back this morning, my dissertation some 25 years ago was actually on the topic of depression. And now we're talking about this again in a very different way as we've learned more about neuroscience and ways we can intervene. So in the upper left-hand corner, you see a woman obviously distraught. In the upper right-hand corner, a cartoon caption of something very similar, but with their world around them very dark and sullen, and a quotation about depression. It's a bit like walking down a long, dark corridor, never knowing when the light will go on. The darkness of depression can be devastating and enduring for many, many people. People think depression is about being sad. They think it's just when you feel down. It's not. It's like a darkness that creeps over you and fills you. It drains all your emotions. It takes everything from you and leaves you feeling hollow and numb. It's not sadness. It's not anger. It's hopelessness. Imagine waking up and there being no color. Walking outside and feeling no wind. Eating a meal and tasting nothing. Holding someone and feeling completely alone at the same time when you're depressed. It's not a bad mood. It's a numb, empty hollowness that seems to never leave. It's feeling alone in a room full of people. You feel like there's no hope left. So what we want to do is separate depression itself, the feeling of sadness or depression. We sometimes mix up those terms with the actual clinical disorder, or as some people refer to it, illness of depression. So the DSM-5 criteria for depression are the following. It requires 5 or more of the following symptoms having been present during the same 2-week period of time and representing a change from previous functioning. At least one of the symptoms is either depressed mood or a loss of interest or pleasure. It may include depressed mood most of the day, nearly every day, as indicated by either subjective report, the person says they feel sad, or observation of others that they appear tearful or sad. Note, in children and adolescents, it can be an irritable mood. So it's very, very common for us to see children and teenagers that do not report sadness, but as opposed to that, they'll report anger or irritation or frustration. Marked diminished interest or pleasure in all or almost all activities most of the day, nearly every day, what depression researchers refer to as anhedonia. Significant weight loss when not dieting, or weight gain, or increase or decrease in appetite throughout the day and nearly every day. insomnia or hypersomnia, psychomotor agitation, restlessness or retardation, just slowness and inability to get going and moving, fatigue or loss of energy nearly every day, feelings of worthlessness or excessive or inappropriate guilt nearly every day, diminished ability to think or concentrate, or indecisiveness nearly every day, recurrent thoughts of death, and not just a fear of dying, but recurrent thoughts of you as an individual dying, recurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. So it may include suicidal ideation without a plan, or of course, suicide ideation with a plan or even an attempt. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So it's not sufficient that someone be sad or have lost weight or be restless or fatigued, but that this must interfere in their everyday life, either work, their socialization, or other aspects of functioning. And lastly, the symptoms are not due to the direct physiological effects of a substance, for example, alcohol intoxication or medication that may be sedating or lead to depression, or a general medical condition. For example, one of the most common effects is uncontrolled hypothyroidism, which can lead to a depressed state. That, of course, would hopefully be treated. The hypothyroidism would be treated, and one would hope that the depression would then go away. We would not consider that part of major depression. So someone must fulfill these criteria to be diagnosed with depression. Depression is a leading cause of disability worldwide, and certainly not just in the United States. Rates are as high as 17% of the US population will experience a major depression disorder during one's lifetime. The National Survey of Drug Use and Health reports that within a 12-month period of time, close to 7% of all US adults will be affected with major depression. The US rates of depression are higher than European, Central, or South African countries, which is very interesting, although their rates are also quite significant. The average age of onset is in young adulthood, from 17 to 25 years of age. And for many, many decades, it's been understood that there is a male to female ratio of 2 to 1 for reported and confirmed major depression, or different forms of depression as well. There's still debated whether this ratio is actual or more females come to attention or diagnosed with depression. The Centers for Disease Control between 2005 and 2007 reported that 1 in 10 Americans were treated for depression, and again, that women were 2 times more likely to report depression. So, suffice to say, this is a problem worth attending to. The assessment of depression is very, very important, and it can take many forms and needs to cover multiple areas before we understand the nature of someone's difficulties, including their presentation, what they present with us, the symptoms they discuss, their overall mental status, clinical history. There should then be a neurobiological survey or assessment, including genetics. Does depression run in the family? Which it often does. Are there medical influences, such as talking about hypothyroidism or diabetes or B12 deficiencies or other things that can impact depression? And the neurophysiological components in terms of brain function, which we will spend a lot of time talking about today. There are also neuropsychological factors, including emotional coping factors, as well as cognitive factors. During depression, people's cognition, their ways of thinking, even their attention and memory skills change dramatically. And in fact, it's not unusual for neuropsychologists to do evaluations on people over the age of 50 who present as though they may have dementia, but in fact could be suffering from a depression. And once the depression is treated adequately, the other cognitive problems disappear. So there are various forms of assessing the symptoms of depression. Of course, self-report is the most common, but there are objective, structured ways of doing this as well. So on the left-hand side, you see a summary of what's called the Beck Depression Inventory, which was created in the 60s by Aaron Beck at the University of Pennsylvania. It was revised in 1996, so it's now in its second version. The BDI-2 basically includes 21 questions that are rated on a 0 to 3 scale. It's a 2-page form, and people are asked, do you feel depressed? Are you suicidal? And they go through a variety of different symptoms of depression, and they're asked to rate it from 0 to 3, 0 being that they have no symptoms at all, and 3 being the most severe, that they have these symptoms all the time. On the bottom left-hand side of this panel, you see the overall scores on the BDI-2 on the right-hand side. Right over here. And these are ratings for levels of depression based on the score. So since it's possible to get a maximum score of 3 on 21 questions, the total max is 63 and the total min would be a 0. And here are ratings. This self-report questionnaire is now available in a computerized fashion through a company called Pearson. They have a feature called Q Global, where you can do assessments online of individuals, and if you run someone through the Beck Depression Inventory, you will actually get a T-score compared to a database that will tell you the degree of their depression and their rating of that. So this is a self-report depression measure, but as we know, self-report measures are not always the be-all, end-all. Some people tend to report more symptoms, some less, and they might even be suffering from the same condition. So there are also objective psychological instruments. On the right-hand side, you see an example of what's called the Milan Clinical Multi-Axel Inventory. And this is an objective inventory that assesses all types of psychological instruments. The other most popular one would be the MMPI. And these evaluate objectively. So they look at how a given patient responds. And based on that information, they determine how similar they are to other people with depression, with anxiety, with psychotic disorders, and so on. So you can get an objective measurement, even in individuals that may or may not report their depression subjectively. Okay. Let's continue on. So, of course, one of the main things we're going to talk about once we have identified someone with depression is the notion that they have these neurophysiological disturbances associated with depression. So one of the common things in the lore of the research that's been done on this is something called frontal alpha asymmetry. And the basic notion is that individuals with depression have excessive alpha over the left frontal portions of their brain, which you can see right here as an example. And individuals without depression do not have this. So since they have excessive alpha over that area, if we do an analysis of asymmetry, asymmetry is a measurement looking at the difference on two sides of the brain. So we look at F3 and F4 and compare the difference. And your asymmetry value would represent how much more alpha there would be over F3 compared to F4. So there's been research talking about that this could be a barometer or even a test to determine if people have depression. And we'll talk about that a little bit more as well. But this is an example of someone with depression on the left-hand side on a QEEG. This is an example of a PET scan where on the left-hand side you see an individual with no depression, a healthy adult. And on the right-hand side, you see a SPECT scan of someone with chronic depression. And basically what you see is this red area, which shows greater activation, red and yellow areas, in someone with depressed over the left frontal, temporal, even limbic regions of the brain. They show decreased levels of activity. And that decreased activity is what is impacting their emotional, or what are called affective network systems. And the result are their experiences of depression. You can see there's even darker areas in the center, which are most likely in the limbic system, if not cingulate area, and those reflect even lower levels of activation. So depression, by and large, is a deactivation of regions over the left frontotemporal limbic regions of the brain in most individuals. QEEG measurements of deactivation would include slower levels of processing. Alpha is one that's been looked at, but in people with more severe depression, you see even slower forms of activity, such as theta and delta activity as well. Okay. Moving on. So this is a functional MRI study which looked at people viewing positive and more negative images and resting states of healthy controls and those with depression. Melancholia was the designation for it that you see here. And again, you see the difference where their deactivation in areas largely over the left side of the brain, including the prefrontal cortex, anterior to middle cingulate gyrus, and areas internally in the temporal limbic regions as well. And even some deactivation in the posterior cingulate and precuneus location as well. Within the limbic system, there's some deactivation of the amygdala in these individuals also. So you can see this combined network of deactivation over areas including frontal, temporal, and limbic structures involved in emotional regulation. Here you see different networks in the brain that we are beginning to understand more about. They designate in green a cognitive control network that you see over frontal and parietal locations, a default mode network that mainly is involved in frontal and parietal activation, and what they call an affective network in red that you can see here is over prefrontal and orbital frontal regions and deeper limbic regions of the brain as well. And here, orbital frontal temporal limbic regions and how some of these networks interact with each other. But in depression, again, we expect a deactivation of these red areas with an understanding of how they might engage or actually not engage with other regions impacting cognition and even the default mode network. So there are various treatments for depression, as I'm sure most of us are aware. Talk therapy is one of the most common. Actually, medication is probably even more common. Here you see an example of what's called RTMS, or repetitive transcranial magnetic stimulation, which has come into the forefront as a approved treatment in the United States and beyond for depression on a physiological basis. Of course, electroconvulsive therapy has long been a mainstay of very severe depression treatment. Vagal nerve stimulation and other forms of intervention are emerging. Neurofeedback's not included here, but we will certainly be talking about that through the rest of our talk. This is from a study published in 2012 from Kahn et al., where they actually did a meta-analysis of different therapies for depression, which were mainly focused on medication and psychotherapy comparisons over various trials. And what they found overall was that both antidepressant medication and psychotherapy studies tend to help about 40 to 50% of the people that participate, which is a very low number, especially when you consider that placebo, as estimated, can help as many as 30 to 40%. The red and blue bars that you see represent the difference between blinded and unblinded studies. So the red studies were blinded and the blue were unblinded. And you can see they basically show the same results, although there are slight differences. Combination therapy of medication and psychotherapy are the best, but they're still only about 60% effective. So the search for treatment for depression, and especially for people that don't respond to other forms of intervention, is very, very important. Okay, so let's talk a bit about the EEG. The first paper related to EEG and depression was in 1936, and they concluded that one's ability to produce good alpha waves was related to one's affective capacity. So if you were able to do that effectively, and I would add equally over different areas of the brain, and regulate that you would be in good control of your emotions. In 1973, Delia and Paris were the first to investigate asymmetry in depression in a case study of psychotic depression, where they looked at a left to right ratio correlated with depression, again, with the left showing greater signs of deactivation. After electroconvulsive therapy, changes were mostly noted over the left hemisphere, which is interesting, and other cases showed significantly lower within patient variability in the left hemisphere. And the left hemisphere involvement was proportional to the degree of depression. However, this is with psychotic depressives compared to non-psychotic. Okay, but even in that sample of their few patients, they saw that some showed greater asymmetry and some did not. Other studies have showed heightened right frontal activation compared to the left in non-depressed controls, which would still give you this asymmetry that people talk about in depression. So this has led many of us to conclude that asymmetry is not a definitive marker of depression. Schwartzberg in '83 reported that EEG findings have not been consistently replicated, which is what we just referred to. In 1998, Rosenfeld was part of his initial study that compared previously depressed, and individuals with no history of depression. That included 77 female freshman at Stanford University. And they had 31 that were considered severe or psychotic depression, 16 milder, and 30 non-depressed. Self-report measures were used, as well as a structured clinical interview. They looked at alpha asymmetry between F3 and F4 reference to CZ over different blocks of recordings. And these are the levels of asymmetry or alpha power seen in those that are never depressed, previously depressed, and currently depressed. And you can see there is a difference in the currently depressed group compared to the other two groups, but that difference is quite small. Following this, Rosenfeld developed a neurofeedback protocol based on his notions, which is what most people have used in the treatment of depression, which is to train down alpha asymmetry in depression. And for many, it can be quite helpful. While long-term follow-up has been described in case studies, there are no controlled studies to date. And in fact, if you look up neurofeedback studies of depression, there are very, very few controlled studies. Other studies produced by the same researcher also found that while neurofeedback changes the frontal asymmetry, antidepressant medications do not. So if frontal asymmetry is the key, and antidepressant medication helps some of these people, but it doesn't change frontal asymmetry, what's happened? Typical treatments described through case studies included several sessions lasting 30 to 45 minutes for greater than 20 hours. Corey Hammond in 2005 reported a case series of 8 patients. They were administered the MMPI. We talked about that as an objective measurement of depression before and after the treatment. They again looked at alpha asymmetry. They had 30-minute long sessions, an average of about 21 sessions per patient where they got no other treatment. They looked at slow alpha and theta, rewarding beta activity, followed by SMR. They had one person that dropped out. And 7 individuals of the 8 showed improvement, but many of these individuals were also on medication and were no longer required to be on medication at the end of the treatment. And here you can see the pre and then the post MMPI average scores. So again, they showed that neurofeedback can be effective for depression and can be effective, importantly, in most people, which is very, very important. As we've advanced in our neurofeedback technology and our EEG technology, we're certainly interested in understanding, well, what else happens in depression? And there's been a lineage of research, especially over the past decade, looking at functional connectivity measured in different ways for individuals with depression. So this is a study published in 2012 in Brain that looked at resting state functional connectivity in individuals with depression versus controls. And what they were able to identify through this work were areas of connectivity involved in different aspects of functioning. This sort of magenta, pinkish purple color represents what they found to be the affective network, or that involved in emotional processing. And you can see very clearly in these regions over the left, temporal limbic to prefrontal and cingulate areas, this is the system that is most actively involved in emotional or affective processing. You can even see this in an inferior view, where the majority are on the left side, some cross over to the right, but it's mainly left-sided activation issues that are at the heart of it here. Another study published in the American Journal of Psychiatry just a year earlier in 2011 looked at resting state functional connectivity in treatment-resistant depression. So there are individuals clearly that have depression that respond to treatment. Usually medication is the treatment followed. And there are individuals that are not responsive to treatment. And as we saw from the percentages before, these groups could be 50-50. So there's about 40 to 50% of people diagnosed with depression that respond to medication, and there's another 40 to 50% that do not. So what they found in panel A are connectivity, functional connectivity patterns in individuals that are responsive to depression. And they identified regions of the brain, including the insula, putamen, amygdala, hippocampus, all the way up to the medial frontal, middle frontal gyrus and anterior cingulate gyrus, the precuneus and parietal regions, inferior frontal, and even medial temporal areas that are all involved in these processes. The dark blue lines connecting them showed areas of hypoconnectivity in individuals with non-refractory or treatment-responsive depression. Panel B shows individuals and their connectivity patterns if they had treatment-resistant depression. And you can see the blue lines change quite a bit. There aren't as many of them, and the ones that exist now tend to revolve around frontal and even cingulate and limbic areas of the brain, temporal limbic regions as well, but you get a heavier weighting towards cingulate regions. And if you, let me get back to that. If you subtract the two conditions, you again get blue lines here. It's a little hard to see, but that tend to revolve around the anterior cingulate gyrus. And they concluded that hyperconnectivity, and other research has done this as well, hyperconnectivity of the anterior cingulate in the context of depression will tend to make people treatment resistant. Which makes some sense because we know that hyperconnectivity of the anterior cingulate that we see in OCD and autism tends to make people stuck, so they can't get out of their mode of being. This is another summary. Sorry, here's the reference. Published in JAMA Psychiatry in 2015, where they looked at a series of 25 different publications that again looked at resting state functional connectivity from fMRI. And they, based on their agreement, they looked at different regions of the brain involved in depression, with again the red areas here being involved in the affective state and their connection to different areas, including inferior frontal and anterior temporal sites of the brain, prefrontal cortices, and again, cingulate and even posterior cortices like the precuneus involved in the default mode network. And it's the interaction and connectivity of all of these that appears to be crucial in people with depression. So the question then becomes, can we measure this type of activity? And of course, can we modify it or train it with neurofeedback? So here's an example of an adult with depression for many years who actually suffered a TBI with a left temporal focus, resulting in increased depression and reading dyslexia and memory problems. In the top here, you see a coherence representation using the NeuroRep software. And this exemplifies what we call hypocoherence over the left temporal area in alpha. And then another way of analyzing EEG data using ICA and Granger causality that shows low connectivity with blue lines. That's the representation of low connectivity over the left temporal limbic frontal regions. So here we see that through QEEG, we can identify the same regions of the brain that research shows us is involved in the regulation of affective states and depression. And we can see that in our individual patients by measuring their EEGs. So here's an example of the same individual, their Beck depression inventory. And again, this is the representation of a T-score analysis, which shows you they had significant depression, another profile called the Symptom Checklist 90, and a measurement of their levels of difficulties in academics with the Woodcock-Johnson, which shows very low performance in language, reading, and comprehension related issues that we also associate with left hemisphere functioning. This is another example, an image of a QEEG from someone with depression, just to show you another example that shows in NeuroRep this left low, very low coherence over the alpha band. And when you compare that to a normative database, you see everything coming out of this left temporal area to probably parietal, frontal, maybe even limbic structures, although this doesn't measure that, is impacted and shows very low coherence. So we have a repeated ability to measure this in the patients we see with EEG technology. So now we want to understand, can we treat this? And can we treat this effectively? To my knowledge, there's not ever been a study treating depression with coherence training. And that's what we're going to talk about, the results of such a study. So about 2.5 to 3 years ago, with Howard Lightstone, the engineer at Eager, we came up with an idea to measure and train coherences, but not in pairs. For a decade or more, in other research we've been talking about, and other people have been talking about as well, when you measure coherence in pairs, like in most QEEG databases, including NeuroGuide, BrainDX, Human Brain Database, and others, they measure coherence in pairs. But there's been research to show us that the information you get when you do that does not reflect actual connectivity at the brain structural level in terms of connectivity. So if you were to compare pairwise coherences to fMRI connectivity or diffusion tensor image connectivity, they don't line up at all. And studies on versions of what are called multivariate coherence analyses, like Granger causality that we looked at above here, are much more reflective of the true reality of connectivity in the brain. So we designed, again, about 2.5 years ago, a relatively simplistic version of training coherence in a multivariate fashion. And we do that with 4 channels of EEG data in what we call QPS, or quad P-sync, or 4-channel coherence. Each pair, A to B, B to C, C to D, and every paired combination calculates a coherence or P-sync value. And then for each channel, we average the 3 paired coherences. So we take A to B, A to C, and A to D. You see they all have black lines. And we take the average of those 3 values, and that becomes our shared coherence value for electrode sensor A. We do the same exact thing for B. So B to A, B to C, and B to D. You see that in these green lines. And the value at B then becomes the average of those 3. And you do the same thing for C and D as well. You can then make a calculation called QPS average, where you take the average of all 4 of those averages, and that becomes your multivariate coherence metric that serves as your reward band in neurofeedback, and you can train that either up or down. In the case of depression, we're almost always training that up because we're seeing examples of low coherence across these regions. Okay, so that's how this coherence metric works. We, of course, evaluate someone, determine they have depression. We process their QEEG, look at multivariate coherence metrics, determine the region of the brain that needs to be treated. So for example, in this case, it would be T5, T3, F7, and F3. So we surround this hypocoherent area and we do multivariate training of those coherence metrics to enhance coherence. Hopefully that makes sense to everyone. Okay. So for this initial study, we had 18 subjects in each of 3 groups. In group 1, they received this type of neurofeedback, the QPS, or 4-channel multivariate coherence training, in the way we described. 18 other subjects were participating in psychotherapy of their choosing. And there was another group of 18 in a waitlist control group for comparison as well. And these individuals were randomized to these groups, but of course they were not blinded. They knew which group they were in, and so did the experimenters. These are the demographics. You can see the age averages in the 30s and ranges from 15 to 65. We do have slightly more female than male, although not 2 to 1. And it's predominantly Caucasian, although there are some minorities as well in the sample. These are the diagnoses. The majority were diagnosed with major depression or dysthymia. And there were even people with bipolar disorder and other forms or causes of depression in the sample as well. Looks like 25 of the sample was on medication at the beginning of the study. 3 of them on 3 medications, 11 on 2 medications, and 12 on only 1 medication. 28 of our total sample were not on medication at all. When we ran demographics comparing the 3 groups, as you can see, there was no significant difference for their age, handedness, gender, race, or medication usage across the 3 groups. So we can then presume that these demographic variables are not responsible for any changes we would actually see in depression. I will say that the neurofeedback training group received 15 sessions. Each session is about only 15 minutes long. So you're only talking about 5 or 6 hours total of training. They're usually done twice a week on a weekly basis. So someone can finish 15 sessions in about 7 weeks. Okay. We then compared the 3 groups for their initial Beck depression scores, and there was no significant difference. But there was a significant difference on their post-depression scores and on their change scores. So we know that it wasn't the demographics, and we know that one of these groups changed depression levels. So we then look at where do we see significance. So our first significance that we see is between the neurofeedback and the waitlist control group. And then again, we see the reverse of that here. And also between the neurofeedback, then the therapy group, and the waitlist control group. So what that would suggest is that the neurofeedback group had the greatest change compared to both the therapy and waitlist control group. And in fact, this is exactly what you see. So what do we see here? These are the changes in depression scores over the course of the training for the neurofeedback the therapy and the waitlist control group, and you can see the change in the neurofeedback group is much more extensive than that of the therapy and waitlist control group. And in fact, if you compare even the proportion of patients within the group, not just the average, but the number of people within the groups that changed significantly. So we had a cutoff of 1 standard deviation in change of score on the Beck Depression Inventory, or greater than 14 points. So we took the normative and clinical depression samples and identified a 1 standard deviation difference. In the waitlist control group, 7 of the 18 individuals had that level of change. So isn't that interesting? Even just knowing you're in a waitlist group and you might get treatment, in other words, placebo effect, helps about 30% of those individuals. And in fact, that's what research has shown on depression. A placebo by itself will be beneficial for up to about 30% of the individuals. Psychotherapy had the same exact result. So 7 of the 18 had significant improvement. Now, for those of us that do therapy or that are interested in it, we might be a little discouraged by this. But remember, psychotherapy research shows that about 1/3 of the people benefit a lot, 1/3 might benefit a little bit, and 1/3 don't benefit at all. We have pretty high cutoff here for our level of considering benefit. So this is not all that surprising either. And in the last group, what we see are the proportion of individuals that showed that level of change with neurofeedback. And you can see 17 out of 18 showed that level of change. So not only is the group on the average showing greater improvement, but almost everyone in the group showed a level of significant improvement. I'll just show a couple examples. So here you have a 47-year-old French professor with a 3-year history of depression, and it also runs in their family. And they previously tried psychotherapy 2 different occasions. They've been on multiple medications. They had also previously done neurofeedback training, power training with one practitioner, and Z-score training with another practitioner without any great success. When we initially saw them, their Beck Depression Inventory score was a 35, which is rated as severe. And on the Milan clinical scale, you can see their depression score and even dysthymia score is significant as well. They also, separate from us, got a PET scan study, which very interestingly showed at various levels the left frontolimbric area having low activation. And of course, we've talked about that. Their QEEG shows this, which is mainly focused on excessive left frontotemporal and even midline frontal alpha. We can even see some down to 6 hertz, but also at 10 hertz. In our coherence analyses, we don't see a severe example of this, but we do see some low coherence over the left temporal area in theta, alpha, and even beta. And you can see the numerical values are lower there compared to other locations. We did this type of training, the coherence neurofeedback training we talked about. You see their pre-QEEG up top and their post just down below with quite significant changes. And here you see a measurement of what we call a comparison map or a difference map. This measures the change in coherence from one EEG to the next. So you can see here in alpha, where we trained them, but also trained them at other frequencies, that there were significant enhancements of coherence. Anything in orange or an orange line represents coherence improving or increasing. And the percentage in the bubbles is the percentage improvement. So this person had an improvement from 13 to 19% over frontotemporal sites, enhancing coherence by that percentage. So any of you that work with coherence know that's a highly significant change. And we see the change in their power maps. And we see the change in their depression measurements. So their Beck depression inventory goes from a 36 down to about a 5. And their dysthymia and major depression scales on the Milan also go from abnormal to normal. Interestingly, on cognitive testing, they also showed improvements to normal levels on executive functions and measurements of complex, sustained, and divided attention. Let me just do one more example. This is a 21-year-old woman diagnosed with bipolar disorder, with severe depression and anxiety, with deficits in attention, executive functioning, and schoolwork, on multiple medications, as you can see. And these are their coherence metrics, where you can see T3 has a significant loading here. And in alpha especially, you can see low coherence in the back on both sides, but more so on the left. This person was trained. Again, we see coherence improvements over the left hemisphere, where we trained them after 10 sessions, reporting that she felt more in control. According to her, is no longer depressed, feels calmer with improved ability to focus, discontinued 2 of her medications under the guidance of her psychiatrist, and was lowering the 3rd. Of course, since she has bipolar disorder, we continue to watch her very carefully and continue her neurofeedback because we don't want this to switch in the other direction. Her BDI went from about a 48 down to about a 3 in just 10 sessions. So some of what we talked about include scientific references, which are listed on this page as well. And any of you are welcome to access to that if you wish. So that's the completion of the presentation of the webinar. And I'm happy to answer any questions if anyone has them. You, again, can put them in the chat feature or the Q&A feature, and I'll be happy to answer those. So one person asked about the effectiveness of coherence neurofeedback and RTMS. So for anyone interested, I certainly encourage you to review the information about RTMS and depression. The research, by and large, shows that it can be effective in a certain number of people. I believe the current figures are about 70%, so better than we see with medication studies. But I think not quite as good as we showed, at least in this study. Now, of course, we need to replicate this to move forward in this direction. But there also is a side effect risk factor of about 5%, sometimes lower, with seizures, potentially. And one of the biggest concerns about RTMS that we don't quite understand yet is the longevity of the response. So will there be will that effect last? And I know studies are looking at that, and the ones that have looked at that initially show that there is not clear carryover and long duration of the effects. And then, in fact, they recommend that people come back every 6 months or every year to freshen their treatment. We plan to do a follow-up of these individuals. This wrapped up at the end of this past summer. So we're only about 6 months away, but we'll shortly have a follow-up to see if to what degree these effects are long-lasting. We don't know that yet either, but hopefully we will find out. Okay. Can you tell us more about the coherence formula? Okay. For anyone that is interested, the actual coherence formula as it's calculated is available through eager. We are working on publishing a study that will list that in the article itself, as well as show some of the initial effects of this feedback. I will also tell you that we did a webinar, I believe, 2 months ago that's currently on our website that where you can go, and that was a webinar specifically on this type of training, and there's more information there about the formula and the different forms of this training as well. And then there's one more question about bipolar disorder. How do you maintain stabilization or intervene when you see symptoms of mania, given the brain can switch quickly? It's a very, very important question. Bipolar disorder is very, very challenging to treat with neurofeedback. We have seen people improve, and we've seen them improve more dramatically with this compared to 2-channel coherence training. But you do have to be very sensitive and do frequent measurements of their brain's activity, because in bipolar disorder, you can have dysfunction on both the left and the right side. One of the advantages of the 4-channel approach now is that we can actually train both sides simultaneously, and we've tried that with some people with bipolar with some success. Next question, knowing there's hypoactivation of the left prefrontal cortex, do you see yourself developing standard protocols for depression for patients who don't have access to QEEG? Well, I'm not an advocate of that. I really believe that the QEEG and these types of coherence analyses are crucial for this, to be able to individualize this treatment. I think one could do sort of an averaging or a guess of what we might look at. So for example, that might include training T5, T3, F7, F3, which I think is the most common protocol. But then you have to decide, and we conclude, okay, you want to train coherence up, but what frequency? So maybe you guess theta and alpha and see if that benefited someone. But I truly believe that if you look at someone's QEEG and individualize it to their needs, that there's going to be a greater level of efficacy. Okay, so we've got another question. How do you handle medications over the duration of treatment? And then something about bipolar, we talked about that already. So it's very common as people work through treatment and as they get better that they don't need as much medication. So we try to work hand in hand with their prescribing physicians to document, as we've talked about today, their improvement, present that to them so that they can begin to lower their medication over time as we continue to do neurofeedback. And in most cases, most people are happy to do that because they would prefer people not to be on medication. We do run into the infrequent occurrence where that may not be the case. And then, of course, the patients or their caregivers need to make some important decisions about how to move forward. And then another question, have you seen patients become manic from neurofeedback? We have seen that in the past. And again, I think very careful regulation and monitoring of their EEG is very, very important. We do QEEGs about every 10 to 15 sessions especially in someone with bipolar, so that we can monitor that over time. But in the case of bipolar, if you have someone with problems on both sides and you train both sides simultaneously, you're far less likely to run into that problem, I believe. Okay. People have also asked about the slides. My plan is to post this webinar as well as the slides on our website, hopefully sometime next week. So you can go to integrated-neuro.com. I'll try to pull that up for you here so you can see that. This is our website, and you can see under presentations, we try to list the slides from some of the presentations we've done. And those are actually available, and you can just click view file and you see all the slides for that presentation. And under education and webinars, we're also trying to list recordings of our webinars. So this is one we did on learning disabilities last month. And this was the slide we did on this approach to coherence training in general. And that tells you more of the specifics of that as well. So you're welcome to view and have any of that. Okay. Any other questions before we wrap up? How do I foresee encouraging this treatment to become mainstream treatment for depressions, including the community mental illness and centers, I presume? Well, I think all of us in the field of neurofeedback know it's a slow process, of course. But I think first, we need to be advocates for this. And we need to get on the same page in terms of what we recommend. And most importantly, we need to not fight with each other, because that does not make us look good in the eyes of others when we're talking about and recommending a treatment. As you as individuals hopefully move forward with this type of treatment, and we'd certainly be happy to help anyone that would like to do that. As you become an advocate and help more people ask for it, more clinicians do it, more patients want it, we begin to get the ability to change the world and the treatment that people receive. So I'm hoping that will be helpful. Okay, any last questions? All right, well, I thank you all very much for attending, and hopefully you can attend another webinar in the future. Hope everyone has a nice weekend. Bye-bye.